Welcome everyone to another session of WIGIL webinar. We have Dr. Sharvari who will be talking on a very interesting topic today. And it's my pleasure to introduce our moderator, Dr. Sadaf, who is one of the senior most women surgical gastroenterologists in India. She is the professor and head of department of Sher-e Kashmir Institute of Medical Sciences, and she is very active in IAST and other surgical gastroenterology organizations. Ma'am, over to you. Please introduce Dr. Sharvari and moderate the talk.
Okay, my video is not working, but I'm audible, right?
Yes, ma'am. We can hear you.
Good evening, a very good evening to all the participants, including our host who are doing the program so energetically, both Manpreet and Shruti. And I congratulate all of you on this new fresh episode of Vigil, where we are going to talk about a very important topic. Yes, all of us are very familiar to Dr. Sharvari, who works as an associate professor in a premier hospital institute of Maharashtra, Mumbai, KEM Hospital. And she is again a very active participant in most of the GI surgical forums and activities. And another important thing, it should not go unsaid that wish all of you a very happy Doctors Day. We are marking a day of a very great contributor, BC Roy, today. And we over to Dr. Shruti to straight away start a presentation so that we don't waste much time and utilize it in some very important discussion at the end of the day.
Dr. Sharvari.
Thank you very much. Thank you, Shruti and Madam. Good evening, everyone, and I wish all a happy Doctors' Day. And I will share my screen. My screen is visible.
Yes.
Yeah.
So it is about the surgical justice. So, as a surgeon, we are always passionate to perform advanced and complex surgeries. However, sometimes a case really teaches a new lesson to us. We always memorize what is taught to us, but there are even few cases which make us give a thought over it also. And then we face a situation of emotional and ethical challenge to give justice to the patient by achieving delicate balance between the science and compassion. So I will present few such cases. So the first case is about a 21-year-old unmarried girl who is residing at Mumbai with her sister, and her parents are residing at Uttar Pradesh. She is a known case of ulcerative colitis since 2 years, on and off on IV steroids and mesalamine. There are episodes of remission and exacerbations, and in one such episode of exacerbation, there was persistent bleeding PR, and she was taken up for sigmoidoscopy, and that led to perforation. Then she was referred to us at GI surgery department for emergency surgery. On that At that point of time, her weight was 33 kg, HB of 8, albumin 2.4, in poor nutritional status. So we took her up for the emergency surgery, and intraoperatively there was perforation in the sigmoid just above the rectosigmoid junction. There was pelvic collection, the colon, in fact the entire colon was fragile. So the surgery performed was subtotal colectomy with Hartmann's procedure, stapling of the rectum at the rectosigmoid junction with endoileostomy. Here, the distal mucus fistula creation was not possible because of the perforation site was located just above the rectosigmoid junction. Postoperative course was eventful in the form that there was purulent collection, purulent drainage through the drains. So we took her up for re-exploration on postoperative day 2, and there were day 12, and there was a little dehiscence at the corner of the rectal stump. The rectum was deceased. It was reinforced, and the wound gape was taken care of, and then the patient was discharged after about 3 weeks. So over the period of next 3 months, we could manage and got her improvement in nutritional status. We could taper off the steroids, and it took a long time for building up the patient again for the definitive surgery. And after about 3 months, she was considered for ileal pouch anal anastomosis. This time we took her up and she was explored, and there was evidence of dense adhesions. There was frozen pelvis. The rectal stump had got retracted into the pelvis, and it was densely adherent anteriorly to the uterus and cervix. So the intraoperative findings, intraoperative dilemmas were the anticipated injury to the uterus and cervix if we go on for excision of the rectal stump. Even if we achieve that, then there was fear of catching that cervix wall in the stapler. Even if we could manage that, then there was definite a possibility of post-operative leak and further leading to cervical fistula, to the pouch to cervical fistula. So there was a surgical dilemma about what to do, and then everything was done, like calling seniors help, and then confirming the findings and possibilities by another expert surgeon, calling intraoperatively gynecologist, and explaining and confirming all the things, and then explaining to the relatives that we are not able to proceed and it is better that we don't proceed with the surgery, and then it was abandoned considering the long-term outcome of the patient. So post-operatively, patient was counseled that we can do the closure at a later date, and she was discharged. But after 1 month, she comes back to the OPD with father now, who arrives from Uttar Pradesh and requests for stoma closure. We explain in detail that the condition, and it is better to perform the stoma closure at a later date after family completion. So after 6 months, she comes back with to-be in-laws, and again we insist for stoma closure, but again we counsel that this is not going to affect the pregnancy. In fact, the pregnancy is 100% possible now, but there will be the chances will be reduced if we go on for the surgery. However, the relatives that time appear to be hesitant. Over the next few months, patient comes back repeatedly to the OPD and insists for stoma closure. We do all attempts, psychiatric counseling, sending the patient and make the patient meet to other stoma patients, but repeatedly she demands for the same. At one point of time, she even says she is ready for hysterectomy, even if the uterus gets injured, but please do something and do this stoma closure for marriage to happen and for her psychological satisfaction. So here comes the situation of what to do, and now I leave this dilemma to you all, and I would like to know what you all would do in such a situation, whether to go ahead with stoma closure and how to go about it. Coming to next patient, here a patient was 75-year-old female from a village place, brought by her medical daughter, a paramedical girl who is her daughter, and the patient has complaints of only recent weight loss with poor oral intake. However, there are no really change in the bowel habits, and she doesn't have really constipation. But her colonoscopy shows ulceroproliferative growth in the sigmoid, and relatives and even the daughter is still in the denial mode at this stage. So how can it happen? On further workups, the CT scan showed not only sigmoid, but the thickening was present at multiple sites, including transverse and ascending colon, and even there was minimal free fluid. The colonoscopy was not possible in the entire extent because of the sigmoid growth. The PET scan, in addition, showed presence of mesenteric and omental nodularity also. CEA was 339, and the biopsy revealed poorly differentiated signet ring cell carcinoma. Now the relatives have accepted at least, but looks like many difficult scenarios. So preoperative counseling included all the factors, considering the means all the factors were explained to the relative and the daughter, that possibility of even neoadjuvant chemo, targeted therapy, stenting, but considering the patient and the condition, we gave our choice that surgery first in view of impending obstruction, and then adjuvant treatment will be given. We even explained the extent of surgery can be determined intraoperatively selectively only, whether it is sigmoidectomy, total colectomy, possibility of intraoperative colonoscopy, possibility of peritoneal disease, then requirement of peritonectomy, the surgery of lap versus open. But one factor was common, that it will require at least temporary stoma, and that was common for in any case. So how much information do patients want or need is another point of discussion. But here the patients and both relatives also say that, doctor, please do anything but try to avoid stoma as far as possible. And now we take up the patient, and we take up the patient for lap SOS open surgery, and on staging laparoscopy there was a peritoneal deposit, PCI index was more than 10, there was mild free fluid also. So the surgery performed was only ileostomy. And now the daughter comes back after discharging the patient and all the counseling. Doctor comes back saying that the patient has gone in depression, patient doesn't want to leave, and she even refuses any further treatment, refuses to go to oncologist to start the chemotherapy. So the quality of life itself is a matter of discussion in particularly malignancy patients. But in a patient like this, metastatic CRC, where the overall 5-year survival is less than 26%, especially in elderly and minimally symptomatic patients, consideration of quality of life is also critical. And in all the new trials, which have the trials about the chemo, immuno, and targeted therapy, quality of life is discussed, is considered as a secondary or tertiary parameter. However, a meaningful data about quality of life is still lacking. So there are various armamentarium, various options in the armamentarium of these patients. But what we have to remember is patients' interest should be taken into consideration first, and then the shared surgical decision making can be the answer. And in this study, which has particularly looked at the elderly patient and stressed upon the matching right patient to the right procedure, they consider that sharing decision making in patient centered approach is important, considering patient's beliefs, preferences, and patient can be considered as expert for himself, and we as clinicians should support in terms of diagnostic and therapeutic options, and the decision should be based on patient's preferences and wishes in long term. Now coming to another group of patients, this is regarding the transplant. So a couple of cases regarding donor in the transplant. So in this third case, there was a recipient NASH-related CLD where wife's blood group was not matching. So younger brother of the patient was the potential donor. So all the investigations are done, and all the psychiatric consultation and even the workup is done, and patient denies, the family unanimously denies any monetary transaction. So on paper everything is just ready. However, we come to know that the something else is also there, and we come to know from somebody else that the donor wants the property to be transferred on his name. Currently also his domestic expenditures, kids school fees were to be paid by the recipient's wife. Donor is actually pressurizing the patient's wife for that. Patient's wife was running only a beauty parlor, and we don't know how she would satisfy all his expenditures and demands. No other living donor is available, and there is a situation of dilemma what to do, whether to go ahead with the donor because everything on paper was clear, or reject the transplant and reject the chance of recipient who surely won't survive on long waiting list of DDLT. In another case of transplant, there was a 45-year-old patient. He was alcoholic, and he he was operated, in fact, for ACLF at another corporate hospital. His elder sister was the donor, and they have spent already more than 30 lakhs for the surgery, and patient has even lost the job because of the CLD. That 30 lakhs fund was raised by selling of the agricultural farmland of that family. Unfortunately, however, there was graft rejection, and they were considering another transplant, redo transplant, and then the patient was referred to us as a public hospital. So now a second donor, a potential donor, was being thought of. That donor was his younger sister. She was recently married and has younger kids. Now the funds are to be raised by mortgaging the home and taking loans and all. The younger sister was very much determined to do anything for the brother, but her in-laws were little hesitant and had a lot of questions that about the donor, as well as what will be the successful, whether this entire exercise will be successful, and we everyone was not sure about the outcomes of retransplant surgery. So here there was a risk of potential poor prognosis in spite of doing all these things, ethical consideration, financial implications, donor safety, and uncertainty of outcomes. So many factors were there. And one more important parameter was, what if the patient starts reading, drinking, and everything becomes futile? So, especially in transplant, understanding family dynamics is an important thing, and it is a collaborative process of family centered medical decision making, intervened with socio-economic condition, cultural and social norms, gender roles, and their division. And we suggest that healthcare professionals should be sensitive and contextual with all these parameters associated with that. Now, this is the last case, although this is not really justice versus giving justice versus injustice type of case. But here I would just want to tell you what all things we as a surgeon are handling and we have to handle sometimes in addition to performing just performing surgery. So this is a fifth case, and this is a 20-year-old female, very young female with 21 weeks of pregnancy. She is gravida 3, aborted twice, and living 0. Her first 2 abortions, spontaneous abortions, were at the month of 1.5 and 2. Query, it was for female fetus. It was not revealed. We don't know, but we had a doubt. And she was third time gravida. She presented with breathlessness and with retching, and which she was referred after 8 days of conservative treatment and somewhere else. So on MRI, there was herniation of entire stomach with volvulus and spleen and colon inside the chest, leading to a Bojdelak's hernia. A congenital anomaly scan or of the fetus has revealed cleft lip and cleft palate also. And now at the end of the day, we come to know that there is alleged history of domestic violence also, which actually was revealed later on. And then she said that there was physical violence to her and hitting by her husband on her abdomen to have abortion, so that the Bojdelak hernia has happened. So it was an emergency surgery, as there was a suspicion of volvulus and thinning and non-enhancement and of the stomach. There was suspicion, but clinically she was stable. So intraoperatively, there was a huge defect of diaphragm, 10 by 10 centimeter, herniation of entire stomach, spleen, part of colon, inside the chest, everything. Mesenterico-axial volvulus of the stomach was there. However, its vascularity was maintained, fortunately, and everything was taken down, and everything was retracted on the right side of the patient, and the huge diaphragmatic defect was closed with the placement of a dual mesh. So during last look during the surgery, we just got everything repositioned. Initially, it was retracted on the right side of the patient, entire stomach and spleen, and then it got repositioned after the mesh placement. And then we noticed there was dirty fluid noted near the G junction, and yes, there was a rent just above the G junction. When it was seen, there were necrosed and sloughed out margins at the G junction, rent of about 1 centimeter at the esophagus. So intraoperatively, there were dilemmas about the primary repair, whether to go ahead with primary repair, whether it will heal, what if it is resection, the extent of resection, with or without cervical esophagostomy we should proceed, what should be done now with the mesh, it is already placed, and what about the feeding or feeding tube. So ultimately, primary repair of the rent at G junction was done with gastric fundal patch. Diverting cervical loop esophagostomy was done along with the feeding jetty, and the mesh was kept like as it is, and this everything was done with continuous intraoperative FHS monitoring. So later on, the dilemmas were doing esophagogram or not, will feeding jetty will be enough for the fetal nutrition or not, whether it will lead to IUGR, what about the cleft lip and cleft palate. And besides this, now the domestic violence comes to hospital. Her husband comes to hospital, again fighting with her with physical violence, doubting her character. And now we know that already an FIR has been already lodged, and police comes to hospital, and the MDT involves the police, lawyer, gynecologist, surgeon, and everyone. Slowly, the oral feeding was started without doing esophagogram with hand compression on the esophagostomy. Again, there was a debate in the rounds whether early closure of esophagostomy should be done to ensure her oral nutrition, but she could manage with compression, and then slowly progress to regular diet with supplementation of the feeding jetty. And she insisted on continuation of the precious pregnancy. And later on, the dilemma was whether to allow LSCS, whether to allow normal delivery, or there is need of LSCS as asked by the obstetrician. So here I just wanted to highlight the, it is not the just the surgery, it is the patient's meeting the patient need in the perioperative period, and it takes a holistic, requires a holistic approach in such cases. And then one stop center scheme can be one of the stations where the patient can get legal support, and the shelter, the social support, medical support, along with the surgical and gynecological facilities. So this was about the holistic approach of the patient. I would like to know now what are your views of the dilemmas, especially in rest of the cases. Thank you.
Okay, thank you very much, Dr. Sharvari. It was we were quite brainstormed listening to so many dilemma-like situation, wherein surgeon has a very important role. That how are we going to take a decision in many instances. But what I understand is when you are caught in between such scenario, we should always go back to oath of Hippocrates, where we can actually, we believe all of us that we can deliver to the extent of our best capabilities. We cannot go beyond our capabilities and beyond our understanding or knowledge of the subject. Most of the things might not be in our hands. So once we take your initial case of ulcerative colitis, wherein you were fixed in between whether to go ahead with the completion procedure and give her an ileostomy closure, which they were so adamant about, taking the risk of all those gynecological complications which we were anticipating, to do a lot of colic inflammatory issues. So therein, maybe differing for better results is always good, but you have a time limit till when you would defer. See, a good options of medical gastroenterology inputs, wherein you can extend the treatment protocols and have a multidisciplinary approach and take calls about biologics, which would help. And if there's a sound clinical response like weight gain and no acute abdomens and further collections, at the end of the day, we need to do something for her. So it can be postponed for 3 months, then 6 months, maybe a year or so. But patient do go into remission, and we don't have to get bogged down or thirsted upon by what the patient dictates to you. She's still very young. She was only 21 years old, you said. And she had to consider her subsequent life also, because if you do one thing for her and if she goes into some complications of not bearing children subsequently, then she'll be back to specialty, the younger doctors who would be there like you for many years, and she'll keep on, then taking guidance from you. So to do right, I think, is more important than to do what is dictated to you. But of course, taking all into comprehension and taking a very, very important consideration of patients' contribution to decision making is important in elective and semi-elective scenario. This girl had come to you as an emergency scenario, wherein you put in an elderly lady who was quite elderly and had come in with an scenario of she wanted anything other than a stoma, and she had lived her life. So I would genuinely think that such patients can participate in decision making. And if we go a step ahead in overworking or over investigating the patient, and you had already done the PET scan, what you could do maximum, or diagnostic laparoscopy, come back and talk to them and tell them that we don't have many options. And the patient is already under anesthesia, so she is not going to give you any advices. So if you would defer that procedure, to me, it would be a better option. Now we'll take in some inputs from other seniors as well as youngsters around it. How would they handle such scenario? It's a very, very important and tricky situation where many a times, if you see in corporate, in your setup, in my setup, the outlook is not like that. We can leave a patient or two, but not in emergency setup where we have to make all decisions and involve them in semi-emergency and elective setup, like a redo transplant at the stake of lot of expenses, because these are all things which are included in our basic oath, which we can improvise it in modern medicinal practices, where you have to take into consideration the whole family, where you are treating the patient into decision making. And think it's very easy is to think, if I would have been such situation, what would I prefer? Having said that, do we have anybody coming in and giving some inputs? Dr. Shruti, can I have the list of seniors in the panel?
Dr. Mathur is here, Dr. Govil is here. We can probably start with them. Dr.
Yeah.
Vibha, Dr. Yamini. Yeah. Mathur, sir.
Yeah, probably they are not
Dr. Mathur, I think
on with they are all of them are muted. So once we talk about liver transplant,
Dr. Mathur is unmuted, ma'am.
yeah, sir, please do come in with your expert opinions as well, because it becomes more interesting when all of us put it together.
Yeah. So, for the first case, I have a question to Sharvari.
Yes, sir.
What is the anal tone of this patient?
Anal tone is normal, sir, for the young ulcerative colitis patients. Yes, sir. Anal tone is normal. In fact, there was a little synecdoche formation, and after the treatment, when we tapered her off, we could achieve the tapering of the steroids and everything. Then there was cicatrization. The anal tone was normal, but the anal opening would definitely require dilatation if we want to have a circular stapler to go in.
Okay, so the question is, why should she have anal canal stenosis in ulcerative colitis? Is it the Crohn's disease? It is not ulcerative colitis.
Yes, so sir, anal because of the entire inflammation, pelvic sepsis, the entire thing has got retracted, and we did not actually done anal manometry, but on palpation it was normal like before.
Yeah, because if the anal canal is normal, then you can take a chance of doing the ileal pouch anal anastomosis. The anal canal has to be normal, structurally and functionally. If you can establish that, then the question is dissection in the pelvis.
Yes, sir. The dilemma was about the completion proctectomy.
Yeah, where the fear is basically the injury to the uterus. And if the patient is saying that, yes, I don't want it, okay, get rid of it if it's coming in the way.
That was her demand.
Yeah.
I mean, that was her demand after frustration.
You see that this is something where we have to give the respect to the patient's opinion. Okay. She doesn't want to live permanently with the ileostomy. It is coming in her way, socially as well as for her marriage. Okay.
Yes, that was
Now,
the situation.
she doesn't care for whether uterus is there or not.
Yes. At the end of the day, at the end of 6 months, she says she comes to that statement.
So she doesn't want. So even if she doesn't become pregnant, it's fine. And we know that in the future, there is a future for uterine transplant. Okay, people have done the uterine transplant, so she has a future if you look at it. So we have to respect her decision. And keeping in mind her decision, you have to make an attempt to do it without doing the hysterectomy. If not, it is coming in the way, then go ahead with the hysterectomy and do the anastomosis, provided the anal canal is normal. That will be my approach, because we have to respect the patient's opinion, because she is facing the social problem.
Okay, sir. We thought that
so we can finish with the first case.
Let
others give the opinion. I don't want to give the opinion on every case right now.
As of now,
We'll
we
go
thought
to the second and third
our teaching that the after family completion, this procedure can be done, and so we have, as of now, we have not done what she is demanding, but we don't know. She has not yet come back after in last 6 months. So we don't know whether she has gone somewhere else, or but we have not done yet the stomach closure and what she was demanding.
Especially on the background of you had taken her for a surgery, planned surgery, and you decided not to go ahead with the
yes, because we know all the findings and we yes.
Dr. Vibha?
So I have to share a similar case. When I was in Gangaram, what Sharvari's first case, there was a young female from Haryana, and she had a total colectomy, not proctocolectomy, and end ileostomy, and she was told that she cannot have restoration because the disease was too much lower down in the rectum. They could not remove also, and her only plea was restoration. She wanted her anal canal to work, and she had kids. She had finished her family, and I took her up. Initially, I felt this stump was on palpation, not much. It was very low down, and still I told her it may be coloanal. She may have to do some Kegels exercise, some incontinence. All this counseling was done, but her only plea was that she wanted her normal passage. And the husband had also come along with her. So we took her up, and I faced all the problems which Sharvari has stated. We had a frozen pelvis. It was very difficult to get a stump to introduce the stapler from below. And even after retracting the vagina to the extent we could, we landed up with a potential fistula. And that was revealed much later. She went home and then she told she had watery discharge from the vagina. And then we did a contrast study, and it showed there was a small hole. So I told that, see, all this was explained to her, and what we wanted to do was restoration, but this comes with this problem. And she was happy that she is able to get rid of the bag. She had a mild discharge. It was not that she was having fecal output, but she had a potential thing. So sometimes if you go by what patients want, you can land up either side of the thing. So I don't think it is very clear whether we need to go by what the patient wants. And many a times they are not educated about what could have gone wrong.
Yeah, and very importantly, as she said that Vibha, that if this fistula progresses and the symptoms increase at a younger age group of 25 or 30, and then ultimately managing the it's a vaginal fistula, whether it's an anal pouch anastomosis or you said it was a colorectal rim anastomosis fistula, it will again require a diversion subsequently if you want to do an extensive surgery for fistula management. So these all things are, stoma is a very, very important area where we come into the rightly, aptly put topic that what to do is right against what the patients want or the family wants. It's still not, people are not able to take that stoma for long, and they always come with a request that please do anything and avoid a stoma, and if it is there it would be temporary, and when are you going to close it. Even those who are picked up as stage 4 disease, what she said, insist about closure of stoma. So I think preoperative communication is extremely important, and taking into consideration the life expectancy, these all young inflammatory bowel disease patients have a long life to go. You have different plans, and terminally ill patients, elderly, CA colon with peritoneal mets, we can take some other decisions. Like you can even avoid a stoma for some time, and if she's not totally obstructed, and give some TPN and some supplementation. Because I have also seen quite a few patients where ileostomy was done with peritoneal disease. They go into severe depression, and it doesn't serve the purpose. They hardly eat anything. Also, we have to keep that in mind in advanced malignancy. So, having said that, we would try right to take inputs about liver transplant patient. With if we have some, people joining us from the transplant group, maybe Professor Sanjay and Shruti herself would put some light on how would they like to take ahead the patients. A couple of patients, she said that retransplant and so much of stake. They had to give away their properties, and a young lady with a small child, that's okay, she can donate for the second time, but the amount of expenses involved in retransplant. So, so would you like to put in some comments?
I would want to hear from Dr. Govil. Dr. Chetan has joined. I think he's been there through the talk as well. So their opinions on the stoma case as well. And then we'll head on to or anyone else has anything to say on the issue of stoma. And I think there's one more funny aspect to this is people who are vehemently against stoma, the kind of patients who do not want it at any cost are usually from the lower socioeconomic status. It's usually a problem of the uh, socioeconomic status as well.
Society, yeah.
It's a societal, it's like a problem of the poor, like just so many problems of the poor that we have in, our country. And in this situation, a lot of other options also go, like at least I can say that in my current private practice, the kind of patients that we get and the options that we can even offer to them, be it stenting, be it TPN, be it any other forms of management, is limited in that kind of that strata of population as well. So it's a very tough decision. Just the views of others, Dr. Sanjay, Dr. Chetan, Dr. Shraddha, she's from a cancer institute, so her views as well.
So, if can I start, or you want one of the others to start, whichever?
Dr. Sanjay, please.
Yes. So, those first two cases make me very pleased that I'm an HPB surgeon and have a pure HPB practice.
Exactly, I wanted to say that.
I would refer these patients to a colorectal surgeon. However, if you want from my memory, and I can sort of have some thoughts. The first patient, you were forced to do a stoma as a life-saving procedure. So, and you had a look and subsequently and found that it's very dangerous to try and to create a pouch. So one of the things I would do, I would not hesitate to do with a difficult patient in particular, is to get a second opinion or ask them to get a second opinion. I would be quite happy to refer the patient and speak to the surgeon I'm referring to and ask them to have an independent opinion. Maybe it might make things a little easier for the patient to understand why we're waiting to try and reverse the stoma, etc. If there were additional people involved, who might give the same opinion, and in fact, if there was somebody else who felt strongly that they could fix the problem, then that's their decision. The other thing is, I don't know whether this is done anymore, but long ago, there used to be this thing called mucosal proctectomy, where you stay within the rectal stump. I don't know whether that is a feasible option in this patient, because I don't know enough about colorectal surgery. But I don't know whether staying within the rectal wall in this kind of patient is feasible, and whether that would avoid or at least minimize the risk of fistula, possibly. With regards to the second patient, I think that in such a patient, especially when they were not obstructed and they did not want a stoma, that the moment the laparoscopy was done, this operation should have been, in my opinion, stopped at that point. And you could have either waited for the patient to obstruct, or I don't know whether the patient could afford it, but the other possibility is whether you could have put a colonic stent inside to keep the colon patent should they have obstructed. So I think that was, I think that patient could have been managed differently in hindsight. The third patient, who is the one who's got the very avaricious donor.
Sir, we'll discuss on the transplant situations next.
So you want me to stop? Yeah. Okay.
Yeah, just we'll take
sure.
the stoma situation.
Sure.
Dr. Chetan, followed by Dr. Madhvi, please.
So as far as the first case is concerned, at that particular point of time when the stoma was done, this patient, I think, because I've been a party to it, was counseled properly that we need the inflammation to settle down, and then we would reattempt the closure. However, the relatives, actually the parents, initially they were very keen to get the stoma closure done immediately, because they wanted to get their daughter married off. And I'm sure that we said that we would wait for another 6 months more before we could go in and reattempt it. But they were not very keen to wait at all, and that is why I'm sure they must have gone to somebody else in Uttar Pradesh and must have got it done. But at that point of time, we thought it is right to just continue with stoma and do it at a later stage. As far as the second case is concerned, yes, stenting was an option, but we thought that because the PCI index was more than 17, this patient would definitely require a neoadjuvant therapy for a longer period of time, and stoma would be better, and hence stoma was done. But then they found it very difficult to manage, and they are very after us to close the stoma. So yes, stenting was an option that could have been done.
Yeah, thank you, sir. Dr. Madhvi.
Yeah, Dr. Shilpi, over to
Dr.
you.
Madhvi, please.
Yes. Good evening, everybody. See, in the case of the transplant, the donor is blackmailing. In such cases, it should not be taken, because if we are very sure of the success of the transplantation, then it can be worthy. Otherwise, when taking into consideration of the psychological and financial conditions of the patients, transplantations with blackmailing should not be done. And another stoma case. Stoma is one very psychological factor. I had one patient operated for carcinoma colon. Stoma was there, and he recovered well after chemotherapy and everything.
but because of the stoma, we should not able to close the stoma because of his malnourishment. He is take less food because of the stoma. So because of that, even in spite of after recovering, he committed suicide because of the stoma. So stoma is one of the psychological factor. It should be given full counseling, and priority of the patient should be taken into consideration.
Very, very important.
Priority of the patient. That young girl stoma is that there is a psychological one, so that has to be taken into consideration. You go for chemotherapy, and if the patient comes with obstruction, then at the emergency we can go for stoma. That is my opinion.
Thank you, ma'am. Dr. Manpreet.
So I think I would like to continue where Dr. Shruti left, that a lot of the patients who come are from poor socioeconomic backgrounds. And I've had a couple of patients like that. They were nice, they had stomas, but when they're daily wage earners, sometimes the issues they have is it's not very easy for them to even empty the stoma at their workplace. So
Yes.
those are some issues which we tend to forget while counseling them. The other thing is with the girl who was insisting that she was even willing to remove the uterus to get the stoma closed. I keep wondering, I mean, if it was just to get married that she wanted to get the stoma closure, what happens when, I mean, the next step is planning a child? So I agree that uterine transplant is an option, but again, I don't think it's very feasible. So in such cases, I do agree that I think the psychological counseling and looking into the background is something we tend to dismiss, especially in government hospitals. Proper psychological counseling and a visit with the social services, if it's there, I think those two should be included as an important part of a stoma clinic before we take any such decisions.
Mathur sir, while you
Okay.
please unmute, my another point is isn't how much of this is like, when patients come, especially for stomas, they come and demand things like, they want it reversed at any cost. For example, if you consider another situation like probably some subacute obstructions or something where we have probably done a stoma, in those cases, how much can you get coerced by the patient's relatives if you know very well that doing such a thing is not in the best interest of the patient? Again, Dr. Mathur, please.
Yeah. So for the second patient, the solution which I can suggest to Ketan and Sharvari is that you can still put an stent to relieve the obstruction and then close the ileostomy.
Sir, the option of stent was thought of actually, but the lesion, as I showed, was at 2-3 places. There was thickening and stricture at 2-3 places, and the sigmoidoscopy was possible only till the first obstruction site. There, the complete colonoscopy was not possible. So she was having obstruction, although she denied clinically, because I think the constipation was just as a usual. When we particularly asked about the constipation, she would say it is always there, or there was actually no recent change, and she, just like all elderly people, she was accepting the constipation, although there was no clinically obviously abdominal distension and complete obstruction, but impending obstruction and SAIO was definitely there. Complete colonoscopy was not possible, and the lesion was there at multiple places. So we thought the ileostomy at one point of the time, she would need definitely.
I'm not questioning what you have done. Okay,
So
what
that
I'm
is
saying
what
now, what you can do, because the patient is an elderly patient, advanced disease. Okay, you want to give a palliation.
Yes.
And she is not comfortable having a stoma. So if you put a stent into the sigmoid, which is the obstructed thing, and then you can complete the colonoscopy from there once you de-obstruct that through the stent, and you will see whether there are further obstructions or not, and they require further stenting or not. It's all a palliative procedure to make the life comfortable. Okay. And then if you are deobstructed all the obstructions with the stents, then the life expectancy is small. So you can make her happy by closing the scope. I'm not saying the first decision was wrong, but that's right, that the way it is done. As far as the first patient, I think Sanjay, I will thank you for reminding about that leucosectomy, because I used to do a lot at KEM hospital. Okay. And so, yeah, that is an option. If you can find the upper end of the stoma, one can do the rectal mucosectomy and then take the pouch through that. So, I think some of you will remember that at that time there used to be controversy of long cuff of the rectum versus short cuff and what are the problems and all those things. So those were the debates at that time. It used to be there. Okay. So that's the option which can be used. That can be tried, but get tried. Okay.
Can I come in, Shruti? I would just, as a moderator, like to say that as Sharvari has put in 3 cases for discussion, I mean, to 3 scenarios, and we are still around the first scenario. Very, very important information given by seniors in the team. And can we discuss the other 2 scenarios as well, Shruti?
Please start, ma'am. I've typed it just now. Yeah.
Yeah, so we can take inputs again from Mathur sir is also into transplant, Dr. Sanjay. And after that, we have another very interesting case. He said that there was perforation of esophagus. And I would start the conversation by saying that I would have done an upper partial gastrectomy and made an anastomosis because probably that had happened on the table. But there was an acceptable procedure which Sharvari has also offered, and we'll take input from everybody that how would they manage such a scenario with a huge hernia and pregnancy, and you don't want a prolonged procedure, and the expertise available to do that kind of resection and anastomosis. So, whosoever would like to take it first with liver transplant, please do come in.
We will tap him in the morning. Okay.
Dr. Mathur, followed by Dr. Govil.
Yeah, please. So please, Mathur sir.
I will put both the patient on DDLT list. Okay.
Okay.
I want to go for the living donor transplant with the another sister donating the organ. Okay, we already have got a lot of debate on the gender disparity in the organ donation. Okay, I don't want to go that path again for this. And DDLT is a good option. The first one, there is definitely commercial dealing which has been found out, whether directly or indirectly. Then it should not be recommended because ultimately the permission has to be given by the head of the institution, even if it is related. Okay, so the head of the institution, the buck stops there. And if it is found later on that there was a commercial dealing, which can happen, because see, suppose this fellow is not given the whole property, and later on he goes to the police and he said that I am not being given, I will promise. That's what happens in most of the cases. Then the head of the institution who has given the permission for such a transplant, saying that it is a living donor transplant, they will come into the picture. They will come into the problem. So you don't want to go down that way. Once you know that there is a problem, financial dealings are there, whether directly or indirectly it is come to your knowledge, I think I will not do that transplant. I will say that you put it on the DDLT list and wait and watch. And the same thing, because it is, I think it must be chronic rejection for the second patient. It's not acute rejection.
Sir, I wanted to ask you, can we justify then when everything is clear on paper? Now, we did the same, sir. We put it on DDLT and unfortunately the patient succumbed on DDLT list. But are we justified that on paper everything was clear? And what if somebody asks that the living donor was there and you have denied?
See, I am part of some of the inquiries where everything was very clear on the paper, and later on the complaint was made, and the people, including the doctors, were sent behind bars. Okay, so I will not advise you to burn your finger in similar situation.
But also, how can we say it was clear if we clearly know that property dealings were involved? Yeah. That means it was not clear, no?
Yeah, so on
exactly.
Paper it is clear.
That's what sir is saying.
On paper, you can make it appear clear, but you know that there is something wrong going on. And as a doctor, as a medical professional, even as a transplant physician or surgeon, it is our responsibility. If we smell the rat, we say that it is the rat. We don't ignore it.
Dr. Koval.
Okay, my opinion may be slightly different, and I'm not sure whether I'm right. What I would have done in such a, first of all, I think what has happened here is that we have found out that there has been that somebody is having a financial thing, but I think this is much more common. This is the tip of the iceberg. With it, we think that everybody in the family is giving out of love for their relative, but I think directly or indirectly, quite often there will be an advantage given to the person who has donated the liver. If there are two sons and one donates the liver, probably, maybe not, but at least in some instances, the property might be, given to the son who donates a little more of the property, if not, So I think but just seeing the tip of the iceberg. So what I would do in this scenario is that accept that beyond a point, I cannot, as doctors, we see the best of human nature and we see the worst of human nature. And I would speak to the relative of this patient and find out what they want me to do. Just tell them that I have heard that this is happening. Is this something, if this is true, and do you want us to go ahead with the donation or not? And if you don't want us to go ahead with the donation, we'll find a medical reason for canceling it. And if you do want us to go ahead with it, then I would just go ahead with it, because the alternative is death for the recipient. So it's something that the patient's family has to advise me. Dr. Mathur is right. I don't know whether I would end up behind bars at some point in the future if I did this, but this is the way that I would have handled this particular situation. With respect to the second one, it's always a problem when you're dealing with an alcoholic liver disease. And especially when I was considering a retransplant, I would want to know about, even the first time, but I would want to know about, number one, abstinence. Number two, if he was not abstinent for long enough, whether this was his first decompensation or whether he had decompensated before and then continued to drink, which makes it very unlikely that he is going to stop drinking, whether he has other bad habits, and what kind of social support he has. If at the end of this, I am convinced that this patient needs a transplant, then I want to know what is this rejection that he had. It's very unlikely that it would have been an acute rejection. I think it would have been a chronic rejection because this guy stopped taking his medication or was irregular with his medication. And if it was a chronic rejection, which is caused by either drinking again or by not taking his medication regularly, then I would be very wary about, in fact, I would not proceed with transplant in such a scenario. Without the family absolutely knowing that the likelihood that this is going to end up in the same situation is extremely high, and I would strongly advise against it. I'm not overly worried about whether the donor is 20 or whether the donor is 40. That is the family's decision. But if this was an alcoholic who had not been taking his medication and developed a chronic rejection, then I think this patient is not going to do well even with a retransplant. That's the way I would discuss with the family.
The second transplant patient, it said the patient was referred on post-op day 16. So somehow rejection itself as if he's...
Yeah, so it's more likely that it was some technical issue. Yeah. Sorry, I have to take a phone call, so I'm going to go on mute.
Who else do we have? Dr. Vibha, Dr. Vibha or anyone else wants to make any comment on the transplant situations or the last case, the social issue?
Yeah, I would say that retransplant, where you come to know there is a, I don't know what was the cause for rejection, whether it was recidivism or it was chronic rejection.
It was
So
early rejection, ma'am. So it was, I mean, if at all, AMR could be the only option there. But I don't think post-op day 16 from what Dr. Sharvari had mentioned. So technical would be more of.
I think today itself I was discussing in the hospital that sometimes when, as a clinician, you interview the donors and before sending them to the coordinators, if you suspect some fishy connection, I would not send them to the coordinator. I would cut it short there itself. I know we are going to save somebody's life, but we have to keep within the act. If you feel that the relationship is not right and someone is trying to fudge the data and have a clearance from the committee, as a clinician, I sign the papers. And I sometimes, and most of the times, it's the doctors who get caught. I would be very cautious when I see something like this happening. I would not send it forward.
Ma'am, that is when the relationship is not correct. Here, the situation is where the
Yeah,
relationship
so
is
for
correct.
that also you have, they take the IT returns of the donor, because there are so many other ways of finding out. If you found it out, I would not proceed.
Okay, okay. No, there's this thing, what just Dr. Sanjay was saying, it's not, something that's not discussed in our transplant groups, that, even amongst blood relatives, be it children, be it parents, be it, the husband and wife who are living under the same roof, taking care of an entire family, there's usually some kind of, I mean, there might be at least in a large proportion of cases, some kind of exchange, if not in cash, in kind, in form of favors, in form of all of these things. Dr. Sharvari, thank you for pulling up that paper from Taiwan on all the family dynamics. I think we should have one like that from India. But
And
yeah,
many a times even we have seen the newlywed, not newlywed means within 10 years or so, the wives are donors, but they are made willing, they are willing donors, but they are somehow made to donate. They are supposed to donate by the family decisions. She is the one who is most, so she doesn't actually understand sometimes even the supra major surgery and all, but it is just her responsibility that she donates. And sometimes then in such situations the wife's brother or her um, parents come to us and say that she is asked to donate. So
that is coercion. Then they need to, this is the right way of going across. Like, do a private interview with the donor and try to dissuade them. Tell them that you'll give a medical reason to reject them rather
yeah,
than.
means at that time the wife is she is willing to donate, but at behind that, before that, these things have already happened, something like that.
So she wants to say that they are vulnerably willing donors, where you have put into a lot of responsibility, like husband is life is very important, and so they consider so many things which it might not be as vice versa true. So most of the time there's a somehow a little gender bias is there in donation.
Yes, in fact, in one case, the 20-year-old son was the recipient, potential recipient, and his blood group was matching with his father. However, the family wanted his mother to donate, even if there was no blood group matching. We asked why his father is having the same blood group and why he is not donating. So they said his father is the chief person in the family,
Yeah, earning hand and so
earning
many
member, and
reasons are
so he
given.
cannot for their son. So mother said, no, no, father is not the donor. I am the donor, and you please find out how I can donate with the swap and all those things.
So we need to have more larger programs of liver transplant in context to donors as well. So they are lawful right beyond promoting and asking people to go ahead and donate, but they are the rightful way of donation, the lawful way of donation, their rights to donate and their rights not to donate also. So
Donor
we need
advocacy.
to, at one hand, we motivate people to donate, but then we have to take care of any bias in donation as well.
Agree.
I think we can discuss as much as we want about the medical issues, but unless the social issues are treated, which is going to take a long time, these questions are going to stay a dilemma.
Yeah.
Mathur's,
I think we are running short of time
Mathur.
as well. So I had put in the chat box that if anybody has to come in with some comments regarding, we have actually discussed in detail only the two case scenario. And my comments about third would be, Sharvari, I might go if it was an iatrogenic. I don't know whether I've got you right, that the perforation was not pre-op, and I would have gone for a resection and anastomosis. I might be wrong because this might be based on a lot of upper gastrectomies being done, and you can mobilize a good segment of esophagus. But then there were so many factors into it. Your patient was pregnant, and she had to, face a lot of domestic violence. And that can be, again, it opens up a pitara of social issues in the in lower socioeconomic status. Having said that, anybody who wants to come in with quick comment, or Shruti and Manpreet,
Actually,
can close it?
it was not iatrogenic, not because we operated,
Okay, okay.
but it was the entire stomach had gone into the
Yeah,
chest.
but it
It
was
got
impending
rotated.
sort of, no, but it was not a dirty old, I meant to say.
The edges were dirty and necrosed. Because of the traction, the perforation had happened at G junction, and because of the first because of the herniation effect, and later on because of our traction, it remained sealed. Otherwise, again, there would have been the dilemma. What I wanted to say, that was revealed later on after placing the mesh.
Yeah.
So I hope it was not iatrogenic. But
No, not
Sharvari,
iatrogenic.
was this
Impending and
traumatic, or was there any component of congenital herniation in this? Was this a proper traumatic diaphragmatic hernia?
that is what we thought, it is a congenital or something, because we just took her
The
up for the
diaphragm rent?
emergency. But later on, she said that there was physical violence and the hit on the belly, and later on she experienced that breathlessness.
No, but then the diaphragmatic rent,
But
what
the
it was,
diaphragmatic rent was wide open, and we on
and there was a
intraoperatively
sac.
we thought it was a huge sac and non-traumatic. But later on, this aspect came in, whether it was because of that. We cannot prove because there was no investigation prior to that.
Okay, there was no
But there
CT
was
also
no
done.
lung hypoplasia.
Levels in media
Lungs
still.
were normal. Lungs, there was no hypoplasia of lungs.
Mathur sir had raised his hand, and after him, Dr. Yamini, do you want to say anything?
No, I was on the transplant scenario, and I said that, which I put in the chat box also, that we must promote the diseased organ donation. That is the solution to all these problems.
Exactly.
And which is not happening to the full extent. What is our potential in the country? If the full potential is realized, then we will not need so many of live donor transplants. And many more lives can be saved. And here the responsibility as a doctors is our medico-social responsibility to create awareness and motivate our colleagues working in the hospital, particularly both in the private and public sectors, those who work in the ICU, neuro departments, that please talk to the family once somebody declared brain dead, potentially brain dead, to talk to about the organ donation. That is the solution.
Thank you, sir. Thank you. We need to use this and every possible forum for promoting organ donation, deceased organ donation. Thank you.
Donation especially. So,
Dr. Yamini, quickly.
Yeah, see, this was regarding the diaphragmatic hernia. I think I fully agree with Dr. Sharvari. Like, what she did was a salvage measure. When we find an unexpected perforation, it becomes more stressful because the time is limited. And I think it was a very good thing to just put a fundic patch, because sometimes when we do an achalasia repair, when we do a cardiotomy and we have a gastric perforation, many a time when we have closed it and done a fundic patch, when we do that, things settle down. So I think a cervical esophagostomy was the best option there. I think, Sadaf, because if we had done another anastomosis, that also will be sitting in our head. There is an anastomosis which would have been pretty high up. It would have got lifted into the thorax, So with the mesh and all that and a fetus inside, I think what was done was the best for that scenario.
Dr. Sadaf, please conclude.
Yeah, I think so. That was an sort of a complex scenario, and whatever the surgeons felt and the expertise available are is the best thing to be done, and to do minimum is also better. But I am not used to using a gastric patch, and you never know whether it would hold on or then you'll have another emergency subsequently. So there are so many things to it, but if it holds on, it's the best thing to be done. And of course, you had the safeguards of cervical esophagostomy. And this particular case needs deliberation in depth, but due to shortage of time, I would say that the take-home messages would be: it's very important to take into consideration patient's decision. It is equally important to do what is right, and especially taking into scenario whether you are life saving procedure, you are into elective, a semi-elective scenario, and what expertise you have and what results you have at your backup. So having said that, I would conclude at my end. I thank all of you to get me involved as a moderator, and I appreciate the efforts Sharvari has put in. And I would also like to tell from this forum that as we have expanded the number of cases and experience, I think we have to keep on changing the pattern of our meeting, and we can take it to some academic meetings subsequently.
Sure, ma'am. It's on the cards. Okay, thank you, everyone. Thank you, Dr. Sharvari. Thank you, Sadaf madam. Thank you to the senior people, Dr. Mathur and Dr. Chetan, Dr. Sanjay, who had joined us. We conclude this session and we'll be back next month, first Tuesday at 8 p.m. as usual with another interesting session. Stay tuned. Good night and happy
Thank you,
Doctor's Day.
everyone. Dr. Mathur sir has also suggested stenting as one of the options, in just to mention in the chat box. I see.
Yeah.
Thank you, sir.
Esophageal stenting is also another option.
Thank you very much, sir, and thank you all others also and all the seniors. And wish you once again happy Doctor's Day.
Okay, bye.
Good night. Thank you very much.
Good night.
Enjoyed all the
Everyone,
discussion.
thanks a lot.
Thank you for joining.